Difficulties. So we're back to the iPhone. We're supposed to do a little streaming through our new software, but we're going to jump in and use our old iPhone and go back to how we used to do it a little while ago. So listen, today we're going to talk about back pain and sciatica. It's one of the most common things that you see in the clinic. Tons of people come here. Tons of people arrive at the ER actually with very severe back pain, looking for solutions. And we're going to just talk about a few things as far as risk factors, why these things might get started, something called red flags, things that we got to make sure we don't show up at a PT place, we get help really quickly because it might be something serious. Then we're going to go through how we look at people, how we do an evaluation. We actually have a live patient here. He says he doesn't have back pain. His wife says he has back pain. We're going to find out real soon what's going on. But we're going to go through an evaluation just to see how the steps we take you through to understand how your particular back problem acts, okay, using the McKenzie method. Okay, so we're going to understand that a little bit. And then we're going to give our 3 top exercises at the end that I would say they're the most common exercise that we give out in the clinic. They're not by any means the only exercise, but they're definitely the most common exercises that we give out. So we're going to give you those 3 and give you a couple of ideas around why this one might be better than this one, and we're going to go through a couple things. And Don, our live patient here, I'm so excited, is going to help us demonstrate a couple of those, and we're going to walk them through those. And just a couple of things on the precautions, okay? Our goal here is really to have you make a better decision for your healthcare, not to be scared. Back pain is scary. Sciatica is scary. You kind of feel out of control. Sometimes you can't do the things you want. And we want to understand that a lot of things, when we're talking about, especially with back, can be very severe, it can be very debilitating, but it doesn't mean it needs a complicated procedure, surgery. Sometimes the solution is a lot simpler than we appreciate. So I just wanted to kind of get that out there because a lot of people say, this is so severe, it must require surgery. And most times, back pain, a lot of it just goes away on its own. A high percentage does after 2 or 3 months. But there's a small percentage that doesn't, and we're kind of helping those people maybe make it go away a little faster and understand what to do and what not to do. What not to do is just as important as what to do. So those are some of the things. Let's talk about first is what are some of the risk factors. So risk factors just mean if you do this, you may start developing back pain more often than someone else. Some things we can't control. If you're in a very heavy labor situation, very physical profession, someone that does a lot of heavy work on the weekends, weekend warrior, gardener, sometimes they're a little higher risk because they're asking a little bit more from their back. Other factors include smoking, circulation to the lower back and such is affected, so those structures don't hold up as well and they're more predisposed to being injured or having some type of disc problems especially. And quite frankly, static postures. So everyone associates back pain, they'll come to me and they'll say, hey, I didn't lift anything heavy. And I'll say, that's fine. I said, what led up to this? I don't know, I just, I was down the shore and I got caught in traffic on the Garden State Parkway in Jersey coming from the shore. And that's the moment where all of a sudden I got out of the car and bang, it hit. So oftentimes, it's not always just heavy lifting or things like that. It's actually really static postures, whether it be sitting. We've seen it with COVID now. People are just on multiple Zoom calls. They're much more. They're not getting out as much for this last year or so, and they're really having more trouble just because they've been sitting more. In fact, Don, our patient was saying, I'm just sitting more. I'm also in a workstation that's just not great. It's not as good as my workplace. So he feels that's part of it, and I agree. That's something that we've seen, unfortunately, in the last year. Kids have been on Zoom calls and virtual schooling, and even in that population. So those are some of the things that are some of the things that are risk factors. And also, quite frankly, if you had a previous episode of back pain, you're probably going to have another one statistically. And hopefully, we can prevent and reduce the chance of that occurring. So if we can figure out some prevention strategies and decrease that chance, because typically you'll get a second one, and unfortunately, oftentimes it's worse. So let's kind of embrace these things. The hard thing is once you get past an episode of back pain, you're kind of like, well, pain isn't reminding you of those things that we talk about. And I like to refer to Dr. McGill out of Canada. He's a big spine guy. Says spinal hygiene, and I really like that word. It's kind of like brushing your teeth. You kind of, once the problem is away, we kind of forget about keeping good movement and healthy patterns for our back. So those are some of the things. one of the questions before we get into the method a little bit is, do I need an MRI or an X-ray for our particular back pain? Unless you have some significant what they call red flags, you don't necessarily have to get an MRI or X-ray immediately. There are some cases where you do, but it's not absolute. And one of the things that happens is if we run to an MRI, unfortunately, over age even 40, 50 years of age, we're going to find something on that MRI that's not going to be perfect. And unfortunately, if we jump to that MRI too quickly, it gets us nervous. And they find that people that rush to that MRI too quickly, they don't do as well as the folks that just kind of managed it and worked it out and tried to do some light exercise and conservative care, whatever, and they actually do worse. There's a lot of herniations, degenerative disc problems, bulges, all sorts of things on MRIs that are really just related to wear and tear on our body, and they're part of the clinical picture. They're not saying we don't want them, and not to say that they're not warranted, but we just got to understand that that they're part of the picture. And what people don't realize is that they'll run to me with their MRI and I'll say, hey, or their X-ray. I said, did you see my MRI? And I'll go, yeah, I did. But it's really important to see how you move, and also tell me the history. Like, tell me what you've been doing. Tell me. That's so important. So remember, if you talk to someone like a therapist or a doctor, make sure you have a clear idea of like what occurred. Really educate that doctor, right? Be concise. We don't have a lot of time. We've got the speed of medicine now. So we really have to kind of give them a little understanding of where you're coming from, what you're concerned about, are you scared, what led up to it, so they can get the best plan of care for you. Now, there are cases we talk about red flags, which you have to go to a doctor immediately. Don't stop, don't go to me, see someone. If you have a sudden loss of bowel and bladder function, you can't have bowel movement, or you can't retain your urine, you got to go quickly. That could be a very serious condition, and you sometimes need emergency surgery. That's an extreme, but you should be aware of it. If you're getting progressively more weaker and weaker, like your extremities, you're starting having balance problems, that's a sign. I don't mean I didn't work out in the gym. I mean you really start getting weaker, you get clumsy, your legs aren't as control, you feel a little off balance, and you have this back pain. It is something you want to take care of quickly. You want to seek help, all right? If you have any kind of fever, something that doesn't change. I have the same level of pain. It's a 7 or 8 level pain, never changes. You could have a tumor, you could have cancer, you could have other things. Most people know when things are really bad. Occasionally people ignore it. It's kind of rare, but those are times when you want to be really aware of that. So that's your kind of red flags. We have videos on when an MRI is really indicated. You can kind of look in our playlist, and also things on back bracing with back pain. We're not going to go into everything here. And also we're going to talk about red flags in a little bit more detail. So check out those videos on our playlist. You can do that after our workshop if you like, and I'll give you a little bit more information. Okay? So what do we do here? We use the McKenzie method. The McKenzie method is named after Robin McKenzie from New Zealand, and he developed a method of evaluating patients based upon movements. And one of the reasons I really like about this system he developed was it's really based upon how the patient responds. It's not based upon, oh, I've got back pain, I've got a stretch for you. It really tries to find the movement or position or posture that actually helps reduce that person's pain, ailment, balance problems, whatever they might be dealing with at that time. It's a very systematic approach. And one of the nice things too is you have someone that's very sensitive back, they easily flare up. In the history, they'll tell you about, I do one thing and my back goes out. This system is very, very gentle and slowly works you through. A very systematic way of taking through movements and standing. You're going to see this with Don here. We're going to take him through a few movements, maybe not the whole eval. Also, part of that evaluation is also the history, which is what is very, very important. And Robin McKenzie really talked about that, is really understanding how that patient's back works. And everyone's back is a little bit different. There's certain things that are similar, there's patterns, but everyone's back is a little different. And so we have to understand how your back works, and also really what your goals are to get back to. Your goals may be very different from the high school athlete that wants to deadlift 500 pounds compared to the guy that just wants to sit at his desk comfortably. Very, very different. And we want to make sure our treatment really reflects that person. So Robin McKenzie developed this system, and over the time, and he was land-based. In the past, they thought the way he was moving people, he was going to hurt him. And over time, became accepted that it's a very safe system of evaluating backs. In fact, a lot of people associate McKenzie exercises with disc-related pain. And as much as, yes, we treat patients that have disc-related pain and problems, it's not just for disc-related problems. And most times it's associated with doing a standing arch exercise, like this kind of lower back arch, or they call it prone press up, where you're doing an arch on your stomach. It's actually based on a method. It's based on how you move and where you have range of motion limitations, and how you move and how your pain changes. So, that's one of the things that probably most people don't really, really understand or appreciate. Even some physicians they've always associated with this one stretch, but it's actually a method. It's how we gather the information and how we take you through certain movements. So that's Robin McKenzie. Interesting guy. He actually has a book called Treat Your Own Back. It's a very, very simple book. It's been around for years. I don't know what edition is this. I can't even see it right now. I need my glasses. But several editions, and it's been sold for many, many years. And it's got some simple things you can do at home to start right away. And a lot of the stuff we talk about are based upon some of his ideas and some of his exercises. So something that you can pick it up on Amazon. I think it's $10, whatever, and it'll be at your house maybe later on tonight even. So anyway, that's Robin McKenzie. It's called Treat Your Own Back. So anyway, so what we want to know is we want to know your story, and I'm going to tell you a quick story we want to see if there's something mechanical, the way you move. Is there something that's triggering your back pain? Don was just telling me earlier, he said, I think I'm just sitting at a crappy desk, I'm home a lot, I'm sitting for extended periods, I'm not seeing customers face to face, so I'm not moving around as much. And I always think of this story, you talk about, things that are very mechanical and very scary, like we're talking about how back pain can be scary. And my wife was sitting one time, and she had it must have been about 2 months of steady kind of neck, and this is a neck issue, but neck and headaches. And she was very nervous and concerned that she had some kind of tumor, something in her brain, something very serious. And if you have a headache that long, I'm a guy, so I only take a headache for about 5 minutes and then I get nervous. But she was concerned, and we finally went to a neurologist and said, let's check this out. Got a full evaluation. Guy went through a whole checklist, very thorough. Guy from New York City that we had seen previously, and he said, Mrs. Williman, I don't really know what to tell you right now. I can't seem to ascertain why you're having these headaches. We've taken through a whole history, really spent a lot of time with us. Really couldn't figure it out. So he finally said, listen, could you give up chocolate, red wine, and coffee? And she said, are you kidding me? What? I can't do that. He goes, well, I don't know what to do right now. Those sometimes can be triggers for migraines or headaches or things like that. And disgruntled, and we were like, well, we don't have any solutions, and still kind of scared about it. And he says, well, have you had your eyes checked? She goes, my eyes are fine. And he goes, listen, I'm just giving you an option, but sometimes if your vision is low, it may cause you to crane over the computer. It may cause some problems for you posturally, because you slowly over time, you slowly adjust and move yourself forward on the monitor. And that can cause, headaches that come from your neck. It's just a mechanical cause. Begrudgingly, Sue went and, got her eyes checked, and there was definitely some vision issues. After about 4 to 6 weeks, it might have happened anyway, just because she more time elapsed. Wore the glasses, and slowly over time, the headaches went away. It seemed to appear that this was related to a position or posture. That slowly, as she was maybe adopting a more forward posture, and her vision was changing, she was maybe adopting something that wasn't great for her neck and might have been producing the headaches. But something changed. It was very mechanical. So when we're looking for things in our evaluations, that was what we think was possibly a neck issue that was related to a posture that wasn't great. What we look for is there's a posture position that's maybe not adequate, or something that you've gotten tight, or a posture that may be contributing to what's going on. And a lot of these things are multifactorial. Don't get me wrong. There's a lot of things that contribute to certain back issues. So our history and what Sue told the doctor and what we probably went into told us a little bit about it. She gave a very thorough history, and we finally nailed it down. It seemed to be something mechanical that was going on in her neck. As she changed that seemed to improve it. She sat up a little taller. She didn't have to crane forward on that little laptop, and things changed. So sometimes there's some very simple solutions to some very concerning kind of mechanical problems that seem like they need maybe something more aggressive. So keep that in mind. I always run that story, and I always go, gosh, exhaust those options first before we start running to other things or heavyweight medications or things like that. So anyway, so we got to understand your goals. We want to talk to you a little bit. We want to get a sense of what you want to go back to, like we talked about earlier. A lot of back problems will get better, like I said, with time. Sometimes they get stubborn. Sometimes we can accelerate that a little bit and figure out what is triggering it. And what I'll say is, I'll say, know thy triggers. Know those things that might be sitting too long. It might be your computer workstation. It might be that sleek race car that's got the very low seat that puts your leg out like so. Is there something you're doing? Is it a type of way that you're lifting maybe in the gym that's contributing to a back issue? Is it because your hips are tight and your back is getting more pressure than it would in certain positions and postures? Those are things we have to kind of work through and see. Sometimes it's as simple as, I've done sit-ups since I was in high school and I've been doing it, and now my back is just not tolerating that exercise that I've been doing for years. So we wouldn't get that from just looking at your MRI or not, kind of exploring what you do day to day. I'll literally talk to people and say, well, take me through your day, take me through a typical day. What do you start? What are things you like to do on the weekends? If there's something that's kind of vague and we're really not sure what might be going on. So we want to look at those things and really explore the history and talk to our patients and all that. So let's go ahead. Let's first go through a quick demo with Don here. I'm so glad he came out. He's done with his work. He's been sitting all day. I'm glad he took a few moments to talk with us. And we're going to just run through as quick as I can, evaluation form and talk to him about his back. And maybe we'll take him through a few movements so you know what we're looking for. And we check during an evaluation of someone that comes to our clinic for back pain or maybe leg pain or sciatica. So let's hit a little round for Don. He's going to come on in. Come on, Don.
Hi, everybody.
All right. So Don, you can sit right here. Good to see you. Good to see you.
Okay.
Why don't you sit down right here and we're going to talk first.
Sure.
First thing we're going to we got a little form here. We're going to kind of run through a couple things that some of the stuff he's going to be filled out already on his forms prior to entering the clinic. We're going to make sure he doesn't have any red flags so we can kick him out of the clinic and tell him go to a doctor or get an x-ray. But we don't know how old he is. There's certain conditions that are more common at certain ages. We're going to ask him where the pain is. We have pain diagrams. Does it run down my legs? Does it, what's going on? So Don, where do you have trouble? Do you have some trouble with your lower back occasionally?
Just in the lower back. It's occasional, only maybe a couple times a year that happens.
A couple times a year.
Yeah.
Okay. What happens when it happens? Is there anything that you're doing particular? Is it a certain activity, or is there any reason why it seems to occur?
Well, I have a tendency to pick up, like I do my own yard work, and I will probably lift things I really should not be lifting, things that are much heavier. I just, because I've always done it. So I'm 59 years old now, and but I still keep doing it, thinking like I'm 29.
Right.
So, but I do all that. Sometimes climbing up the ladders and cleaning out the gutters, and you stretch and stretch. I want to get the last bit of leaves out of there. So maybe that. And then I don't feel it, but then sometimes I will feel something.
Right.
So.
It's kind of okay. And you were saying to me before, you were saying the last year has been a little harder because we talked about just sitting a lot. You were saying your workstation.
Yeah, for the last 14 months, we've been working remotely. When I was in the office, we had a better chair. Plus, one thing, we're on the 5th floor, so I rarely take the elevator. I like the stairs, up and down the stairs, up and down the stairs. And being in sales, doing things in person, seeing customers, and after that, you would do its cold calling, which is prospecting in person, walking around buildings, trying to drop off card, trying to talk to someone who makes the decisions, for buying. So there's a lot more physical activity.
Right.
Now, for 14 months, I have a downstairs guest room and have like a reclining chair and an old TV chair. I do that, and I have my, the bed there is my desk, and then I move into the kitchen, which is a little bit better chair, but I don't have good chairs, and it's been like that for about 14 months now.
Yeah. So we look at workstation setups, and sometimes we'll say, hey, Don, take a picture of your workstation. Maybe we'll give you a little feedback on things you can make, little changes to, maybe just a simple change to a chair or, a little modification, jerry rig something that he can do at home. So that's good information. We can give him the best stretch in the world, or the best activities, but if he's doing the thing that's triggering it, that may not make the complete change. And then he's going to give up on it, you talked about, so you really like to garden, you're really active around the house,
Yes, yeah.
Okay, so that's
raking leaves, cutting grass, all that.
And I got to tell you, our gardeners and our people that are very physical, there's a lot of like, one of the risk factors we didn't talk about a lot was a lot of flexion and rotation, like in the garden, kneeling, getting to certain things real low. I used to work as a carpenter, we'd be kneeling a lot, flexing, turning. That flexion and rotation is really hard on a lot of back problems, especially people that have a disc related problem. That'll be especially hard. So, you know, if we're not doing it consistently, sometimes our back isn't as resilient. We're just not as strong from doing it. And, you know, it's not a certain part of the year. Maybe do you do it all year round? Are you doing it outside? Or
Well, it's seasonal. Like last winter, there was a lot more snow shoveling. The winter
Right.
before was milder.
Right.
The leaves, the grass cutting, you know, the falls, the leaves in early winter, then the grass cutting, you know, April to October. That's consistent.
Okay.
Shoveling my own snow. You know, sometimes you can have a heavy winter, sometimes it's a very
Right.
light snow for the winter or no snow.
So it varies. And this is pretty typical. I mean, a lot of people describe, you know, once or twice a year it gets thrown off. Like, how long does it bother you? And it kind of spikes. Does it bother you for a couple of days?
Yes,
or
yes.
A couple of days,
Mhm,
okay.
yeah.
So sometimes 2 or 3 days, and that's really it. And it sounds like it's been many years that you've been had this, it sounds like, and it's
Yes.
been okay, you know.
So if I do
it's
that, I
not-
do some little stretching and then sit-ups or something like that. I'll do some sit-ups and that'll make it feel a little better.
Yeah, so sit-ups are one of the exercises that he likes to do. It seems to help his back. And the irony is that I would typically say not to do sit-ups. That would be something that's good. It's not the core exercise I would pick. And it might be, you know, it might be somehow correlated to maybe some problems you have in his back. I don't know. I'm just saying that's why we got to talk to Don and not just, you know, just assume certain things. So, was there anything that started like your first episode of back pain? Was there anything like any big moment or just
No,
one day you
it's-
kind of you had some?
I've had it for probably maybe 25 years.
Yeah.
So,
It's been a long time, so, you know, say we know it just kind of came on gradually, and that's a very common scenario, you know,
not,
it
not
doesn't have
like
to be a
picking up
trauma.
something heavy that, you know, I really shouldn't have done that and then it started
Right.
from there. I can't really pinpoint it. It's just
Yeah.
something that's
Yeah,
maybe 25, 30 years or so.
and that's very common, I mean, that's a real, you know, typical history. So the next thing I'll ask you about is, when you do have it, like right now, you don't have any pain right now,
No,
right?
no.
Yeah, any pain, so we'll ask, are the symptoms constant? At every moment, do you feel something? Or is it kind of on and off? Is it with a particular position, posture, movement, time of day? We'll say, one of the things we'll say, you know, what makes it worse and what makes it better? Does bending forward make it worse? Some people say, no, actually it makes it feel better. Does sitting make it feel better, or getting out of a chair? What are the things that you have trouble with? And we also want to get a baseline so we know if these things change, we know we've given him the right exercise or right movement. So those are some things we want to consider. And you know, what makes it better? Sometimes people find I did this stretch and gosh, it feels better. Sometimes the stretch is temporary, like they do it and it feels good and then it doesn't do anything after that. And there's a lot of different creams, massagers, and things out there that'll make something feel better, but sometimes they don't really solve the problem. And Don's problem doesn't sound that bad. It sounds like 1 or 2 days he's feeling pretty good and he's back in, which is wonderful. You know, I'm really glad to hear that. Sometimes he'll have certain things as far as range of motion loss, which we'll see in a second. Occasionally, he's like, wow, he's kind of tight in these areas. Almost as an injury prevention, you probably want to work on this or this, just to decrease the chance of it ever coming back. And sometimes it comes back worse. You could have, you know, something that progresses to like sciatica. Or have you
Yes.
ever had any kind of symptoms down into like?
No, not at all.
That's
No.
fantastic.
No.
Good. Other things we'll ask about, we'll ask, you know, coughing, sneezing, laughing. Do you have any pain with that ever when the back is bothering you?
No.
That'll give you an idea of how fragile it is, how sensitive it is. The idea is that as you cough and sneeze, the pressure within your trunk will put pressure over the lower back segments and sometimes can give you a little bit of pain and discomfort. So we'll ask that. Another thing we'll talk about too is, you know, what's your sleeping posture? So what kind of bed do you have? Like, do you, you know, is it a comfortable,
regular double bed mattresses? It's
firm,
yeah,
soft?
firm mattress, but it's older. It's like 20 years old or something like that. So
Yeah, so it's, you know, a lot of people got these mattresses. You know, it's like,
Yeah.
you know, it's the least exciting spending money. I mean, unless you're really having trouble in the morning, I'll tell people, you know, if they really have a rough time in the morning, sometimes I'll say, you know, you've done all these good things, maybe a mattress may help you. And they find like medium to firm mattresses. There's a Journal of Chiropractic actually talked about that was the most popular for people that had back pain. So that might be something you want to do if you have morning pain. So I would
Yeah,
say,
yeah.
you know, just explore the option. It's a costly option, so I don't always say run to it. I say let's try other things. They're not as costly, but that could be something that could help you out. You could also use certain types of pillows and things like that
that may help you. But unfortunately, whatever position we start in, we often move throughout the day, or throughout the night, I should say. So we're always changing, so it's hard to use like sleep pillows and things like that
Yeah.
with any kind of success. We want to know what kind of medications he's taking. Is he taking an anti-inflammatory? Is he taking like our narcotic right now? If he was, he's obviously not having trouble right now. Just to get a sense of what he's tried and what seems to help him. Steroids, we take that down. We want to know if he's had some imaging. He might be scared about what someone told him about his MRI or X-ray, and we want to make sure we understand what he's got in the back of his head, that little, am I nervous about a disc bulge or something? Because that also tells us about his confidence to try new things and to try and exercise. He may be terrified based upon an MRI and X-ray that showed degenerative discs and problems, or who knows. So we got to make sure we talk to him about those things, so we understand what the expectations are for this movement, and so he understands how to safely go about the evaluation, and also just the exercises. Sometimes I just do the evaluation and I don't even give treatment. I say, let's wait till next time and we'll see you, because you seem like you're getting kind of flared up. I see you're kind of nervous, and we take a pause and I say, we'll start the treatment next time. We'll start, I promise. Come back the next day or next couple of days. If you have any questions too, please feel free to pop them in there. If I can't answer it because I can't see the questions right now, I'll be sure to try and answer them in the comments section if you have a comment. So, all right, so that's our basic thing. Last thing is night pain. When I talk about night pain, I mean not just a little uncomfortable. I mean night pain, like horrific night pain, could be a sign of a very significant pathology, like a cancer, tumor, something that is really unyielding, or infection. And also unexplained weight loss, same idea, cancer, something like that. They call it the I wish question. Any unexplained weight loss? No, I wish. That's the I wish question. Also, if they had a recent surgery, sometimes you can have an infection related to a surgery. So we have to be aware of that dynamic too. So let's check and see how Don's posture is. He's been sitting here for a little while. He was a little bit forward, but I think he actually had pretty good posture. He was sitting up most of the time, talking with me. It's good to check them when they don't think they're being watched. Sometimes I love to catch people. I call it the parking lot assessment of gait, and I'll see okay, they're walking in late, or they walk in the waiting room, just to see how their movements are. Are they naturally kind of forward? Because as soon as I start looking at them, everyone's got perfect posture. So sometimes that can contribute to what you're feeling. So, but Don looks pretty good here. So let's go right to the movement. So let's have you stand up. We're going to have Don face this direction. We got him in view there? My son's the videographer here. Okay, let's go ahead and just flex with it. So before he even starts, we want to ask him, is he feeling anything right now? And let's pretend, I'm going to pretend, Don, you're actually having more trouble than you are. So I'm going to say, right now you've got some lower back pain and left buttock pain. Let's say he's got that right now. So as you move forward, we're going to first check how far you can move. So let's step forward, lean forward, and go down the front of your legs as far as you can. And just you want to go as far as you can. Just tell me how that feels. Not bad range of motion there. Good. And then back up. You're going to place your hands on your hips, and you're going to lean backwards. You're going to keep your knees straight, and you're going to lean back as far as you can. Now I got to get a little bit further back. You can't see me right now, but okay, that's not bad. Let's try and keep your knees straight there, and let's see how far you can go. So Don's a little bit tight. He's not having any pain right now. We made up pain right here, but he's not in pain right now. Now let's go ahead and turn this way, and we're going to do a side glide. I'm going to show it first. We're going to basically side glide this way and side glide this way. Okay, so I'm going to take you through this, Don. So just move with me. Any pain with that at all?
No.
Okay. So then, based upon what we saw, he's got pretty good motion actually. Going forward, he could touch his toes. I mean, that's pretty good. I mean, 59, he's going right to his toes, no problem at all. Didn't even bend his knees. But backwards, he's a little bit tight. So if he had pain, we're making up pain right now. Let's say he still has the lower back pain and left buttock pain. What we'd have him start doing is we'd have him turn, place our hands on our hips, and we're going to have him do what we call repeated movements. So we want to see how he acts and if he actually improves his range of motion, how his symptoms are. But since he's got fictitious symptoms like right in the lower back, we're going to kind of make this up a little bit. But let's kind of lean back as far as you can. So you're going to go pressure on. Good, and then pressure off. Try and keep your knees straight. You want to get to the very end of the motion, so it's pressure on as far as you can back. Good, pressure off. He's gonna do it a series of 10 times, all right? I'm not gonna take him through, he's not gonna do the full series. Depending on how he feels when he's doing this movement over and over, we're gonna see, wow, let's see if his range of motion changes. Wow, he gained 25% more motion. Hard thing about spines is you only have one. When you have extremities motions, you can see there's a difference side to side pretty readily from a left to a right. With the spine, you really got to take him through it to see, is that his normal range? Maybe that might just be the way he's built. So we would take him through that motion, and we want to see if there's a change in motion and also a change in symptoms. A good sign, if this is the right exercise for him, is that he'll say, hey, Tom, I was doing that arch. My pain, I'm just going to turn around, Don. The pain used to be all the way across here in the buttock. Now it's no longer in the buttock. It's now a little bit more central. It's more right about there. And that's often a sign, even if the pain feels worse, that's actually the right direction. We want to have him arch more. And that's one of the common directions people are tight. We're sitting all day like this, so we typically lose the ability to go the opposite way. So if the pain, let's say if Don said, okay, the pain's across here, it's in my buttock, I'm doing the stretch, I really think it's the right stretch. Now I'm getting pain radiating down my leg into my calf. That's a sign that we most likely have to have him stop, okay? I would say it's a yellow to a red flag. We've got to have him stop that motion, especially once he stops and it's still there. We absolutely want him to stop that motion, and we kind of stop the evaluation. But we want him to do the movement first before we do any kind of movements with him, okay? Then the concept is called centralization and peripheralization. Centralization means it's going to the origin of where it's coming from. It's becoming more central. Peripheralization, the bad direction, is when it's actually radiating further away and down. And that's what we tell the patient, okay, Don, you're going to go home. Let's turn around. You're going to go home. We're going to have you do this stretch a few times. We're going to see if you have an improvement in range of motion. If he was having pain, if he was having pain, we'd give him these instructions to, let's say, if you feel like it's getting worse, meaning it's radiating down, bad sign. If it's starting to move up to the central and getting more focal, right to, let's say, around the lower back, that's a good sign. If it doesn't change at all, that's fine. Then you can continue to stretch it. Sometimes you wouldn't have an immediate change in the symptoms once you start. Mm-hmm. So those are some of the things we'll do. So we normally do a standing assessment first. Depending on what we find, if we say, wow, there's a big change, you say, Tom, that was great. Like, that took my pain away. If he was having pain, it got better. I feel like I can move better. You'll also notice that when people have improvement in one direction, they'll oftentimes have an improvement in the other direction. So that's something we'll recheck after they do the stretch or after the, evaluation. If we don't see anything right here and says, well, it's not really a clear picture of what's making it worse or what's making it better, then what we'll do is we'll have them do a series of exercises on the table. So let's try that, Don. So the first one, we're gonna have your head up this way. Head up this way, on your back. If we're not sure, we'll do an exercise called a knee to chest, okay? So knee to chest, you're gonna put both your hands like this behind your leg like this, or on top of it, yep, both sides. So bring this leg up, and you're gonna pull both your knees toward your chest, and we're trying to flex and flatten the lower back, okay? Flat lower back, and then we're gonna release it. So pressure on, and then pressure off. Same idea, we're gonna do a series of 10 repetitions and then see if there's a change in his symptoms, good or bad. We wanna know how it acts. We're trying to understand how Don's back acts. We're not trying to assume that he's gonna be better with one particular movement or posture. So let's assume we did 10. Don says, I don't know, doesn't feel great, doesn't feel worse. I don't know, I don't know what to say about this. Still have the pain in his back and into his left buttock. So Don, let's lie in our stomach now instead. So we're going to put our hands, we're going to say, Don, put your hands underneath your shoulders. We want to do a mini push-up. We're going to keep our back, or I would say this portion of us, on the table, and we're going to push up as high as we can. So you're going to push up, up, up. And I'm not applying pressure to him, and then you're going to slowly come back down. We're going to do a series of 10. We just use 10 as a round mark, and then we kind of say after 10, how are we feeling? Some people can't even get into this position. You have someone that's having a lot of pain. Sometimes we have to start with a pillow underneath their waist just to get on the table. Like I said, every person's a little bit different. So once we get to 10, we also want to see if there's a change in motion. I'll always reassess and check the motion off the table. We normally will send people home 2 or 3 days and say, try this exercise, depending on the person. That's the last one. Let's have you sit up, Don. So Don's in all these stretches. We sat down with him. We listened to his history. We said, what things make you worse, make you better. Sometimes, when people say sitting is worse for me or things like that, oftentimes the reverse of sitting was maybe reversing that arch, maybe doing an extension exercise is better. Some people that have other conditions like stenosis, which we haven't really gotten into, they really like to sit down. They hate standing. They hate walking. People that have certain types of back problems, disc related problems, they typically like to walk. They like to be upright. They like to stand. They don't like to sit. They don't like to do anything that's requiring, you know, flexion or rotation. So we kind of look at the history to tell us which exercise, but what we really go by is what Don feels and how Don feels once we have him move certain ways. Most times I won't do some hands-on stretches until the person goes back for 2 or 3 days and tries these stretches on their own. Okay. And basically after 2 or 3 days, I'll say, Don, one of the things we'll say is, you know, especially if sitting is a trigger, like from the history, we'll say, wow, I can't sit more than 10 minutes, let's say. I'll say, don't sit more than 10 minutes. If someone says, well, sitting's just kind of a problem, I'll say, keep it to 20 minutes. Do this exercise 10 times every 2 hours, and it's about 5 times a day. Be aware of your posture, and hopefully doing some gentle walking, as long as that's not an exercise that typically makes it worse. That's a very simple prescription of what we give here. And it's not based upon a particular structure that's affected. It's not someone that has a disc problem or stenosis. It's really based upon the overall picture on what Don tells me based upon those movements. He'll say, Tom, I'm doing this movement that really bothers me. That's clearly not a movement that we're going to send him home with. Okay? In some cases, I will do hands-on stretching the same day, but most times I want to see how they do first, so we're sure that, you know, most likely Don's not going to do anything that's going to hurt you. Like, he's going to say, this hurts, I don't care, centralization, peripheralization, I'm not going to do this stretch right now. It seems like, you know, it's not right for me. And we send him home with these precautions and, you know, what's good and bad pain. And that's what that peripheralization, centralization, you know, pain with movement, but as long as once you stop the movement, it's not worse. Those are all the things that arms that patient and empowers that patient. And the more they can do on their own and have an active movement and restore it, the more confident they're going to be, and they're going to feel less fragile. All right, and that's really important that we get we understand. I don't want to scare people. I say this is a high-risk activity. This is something you want to be a little careful with, but we want people to feel confident and realize that there's things they can do. They can be, you know, and we'll give them certain limitations, like try this or try that. But we want to keep you, most times, as active as you can so you don't get deconditioned or have other problems. So that's basically part of the evaluation. What we didn't show is we'll check strength and all that, make sure there's not any kind of nerve weakness or something that's more concerning. But we talk, that's part of the red flags and other things like that. But we want to really just, the whole time we're really talking to him and making sure he understands what's good and bad pain, and based upon the evaluation, there's a lot of back and forth here. Okay? So that's the evaluation. Let's go through the 3 stretches that I give out most commonly in the clinic. Okay? The first one is actually the one Don was doing standing here. So let's go back to this one. So the standing lumbar extension. I'll give you a couple scenarios. Let's turn and face that way, Don. Most times people, like Don is actually a little tight, even though he says he feels fine, he is a little bit tight. Like, let's lean back as far as you can. Place your hands on your hips. Keep your knees straight. And you're going to basically lean back as far as you can. Pressure on and then pressure off. Okay? And I'll tell people to do this series of 10 times, upwards of 20 every 2 hours, which we talked about. This is probably one of the most popular ones and the ones you'll get the greatest relief from. All right? What we don't want to do after Don does 10 is we don't want him to stretch in other directions. Like, we don't want him to start trying to work on touching his toes or stretch his hamstrings. We want him just to do the one exercise, but not do other movements that may contradict the arching exercise until we're sure. Eventually, he's got to flex. His life is gardening and working around the house, bending forward. So let's make that the last one. Actually, he got a little motion just in a little period of time he's been working on it. So that's the standing lumbar extension. It can be with people that have central low back pain. They may have pain in both buttocks. It could be going down both legs. You just have to know your starting point. Once you do the stretch, is it starting to move up? Sometimes you'll say, wow, the pain's out of the right leg, but it's still in the left. You can keep on going. As long as the overall movement is up in this direction, that's fine. You can have patients that have just symptoms on one side, okay? This is still one exercise that may improve their situation. There are people that are non-responders. This is just, nothing really seems to make it better, okay? But you only know until you have them move it. And I would say within 48 to 72 hours, 2 or 3 days, you'll see a pattern to it if they're compliant, if they actually do it. You got to get that 5 sessions in a day. You got to sprinkle it through the day. I always tell people. And that typically you can see patterns to it. So the other exercise is the one that Don was doing lying on his stomach. So let's go back to the one on your stomach. This is the prone press up. these two exercises are the ones that everyone associates as McKenzie exercises. So Don's basically going to push up. We actually will have people move their legs a little wider here sometimes and push up. And I'll tell people, breathe in, breathe out, and just let your back slacken a little bit at the very end. Just let it kind of sink in and then back down. Over all these stretches, you have to get to the end of the motion before you stop. And I always have people, not always, I have people like pause for a couple, go breathe in, 1, 2, and it's like, try that one time down. Just relax, just breathe in, breathe out. But at the top of the motion. So go all the way to the top and just breathe out and let your back sag a little bit. Good, and then back in. That's it. Let's do this, the last one. And then back down. This is hard if people, for certain people, you know, it's a lot of arm motion, so I love when they can do the standing version of this better. You can do it on a bed. It's a little bit better on the floor, like a firmer surface. But you got to get those repetitions. The repetitions will start teaching us about how your back reacts. Sometimes it's not as clear on the evaluation which movement is better for him, but we'll send you home with one of them that seems the most likely that'll help you. But they have got to do it. You'll say, listen, if you don't do it at home, I can't help you. Like, wait till the next, give it a couple more days if you haven't done the exercises. But those are some things that I want you to consider. So that's number 2. We have a video on my top 3 McKenzie stretches, and they can also look at that, and I'll go into a little more detail. The last one is the least common of the 3 that I give out. So let's have you stand up, Don. So I'm going to show this. You can do this in two ways, just with the camera here. It's called a side glide. So basically, some people you'll see they're shifted. Like if you feel you're like a little bit shifted in the clinic like this, what we want to do is correct that shift, and we want to correct that motion by, let's say we're out like this. And we'll take our hand, let's say, against a wall here, and we'll apply pressure this way. Pressure on, pressure off. So hands on the wall here, outstretched. Pressure on, pressure off. In fact, let's try that. Can we turn that camera, Ryan, over to show Don over here? So one of the ways we can do this here is place your hands against the wall. If you don't have a shift, if you're shifted away, let's say Don came in and he was kind of crooked like this. The crooked side, wherever his hips go, would be the one that's away from the wall. So he'd essentially apply pressure on and then pressure off. Clearly he doesn't have any restriction. We got to make sure his elbow is nice and straight. So pressure on and pressure off, okay? And he's going to do this series of 10, same idea. Monitoring his symptoms and see if there's a change. If it starts getting worse, we obviously want him to stop. This can also be a case where, that's good. Another thing is you may see someone that's kind of shifted like this and they'll walk into the clinic like this. I still remember my stepfather coming in one time golfing. He was on the course and he was shifted like this. Other people just feel like they have pain just on one side. Typically the painful side is the side away from the wall. So let me demonstrate this time actually. So if my painful side is here, we're going to place our hand on that side. That's the one that's going to be away from the wall. So we're going to place our hands here. So you're going to go pressure on, pressure off a series of 10 times. With this one, once you feel like the pain is under control, sometimes you have to follow it up with the standing arch at the end. It's a little specialized. I don't give that one out as much, but that one is one of the ones that you sometimes see in the clinic, but the first 2 are the ones that you most commonly see. There are people that benefit from other stretches. These just happen to be the top 3 that we normally give out based upon how they respond and how they respond in history. So anyway, so that's our evaluation of Don. Don would go home, like I said, in 2 or 3 days. We'd ask him to come back. If he was having more trouble, I'd say, hey, let's give us a call at the clinic. If you're not sure what you're doing is good for your back. And then we learn a little bit from it. And then based upon that, once we get the symptoms under control and the pain, Don says, wow, I don't have any buttock pain, I don't have any lower back pain. Then we start having him do stretches in the opposite direction. We want to do, they call it the recovery of function. That merely means that we want to start flexing. We want him to start getting back to activities because he's got to flex in life. He's got to tie his shoes. He's got to bend forward. He can't always keep that back, rigid and everything kind of locked in here. So we can't always keep that extended and neutral back, they'll call it. So that's kind of a brief overview of how the McKenzie method works and how we look at backs and see how they move. But like I said, we really want to learn how your particular back works. And part of it can be imaging. It can be an MRI and X-ray. Part of it's the clinical exam. That's like how Don moved, how he felt when he was moving, where he started, and also the history. And lastly is kind of knowing what he's telling you. You know, how did this start? You know, I was doing burpees, and that's when this thing kicked off. You know, we could do all these exercises, he could feel great, and all of a sudden he'll go right back to the burpees. He may not be ready. We may want to replace an exercise that he loves with something that still works the core and gets him stronger, but doesn't put his back at risk. And we want to, you know, save those things for times when we can't protect him, like the gardening and things like that, where he can't modify. He just has to do it a certain way. He's got to bend over a certain way to get to do certain things. But we want to protect him on times we can. We want to make sure we look at his workstation. We want to give him some options with that and really make sure that's not contributing to it, and give him strategies so he can kind of decrease the chance of this coming back. So that's the method. I hope you got something from this. A lot of the topics we went over, you'll see on our playlist. Check it out and see if you have anyone that's having some trouble. You can send them this this video. We'll be posting it with a little description at the bottom. And anyone that wants to, if you've watched this video, and we've actually put out our book, put out my book, just give us your email. We'll add you to our list. So once it comes out, you'll get a discount on the book. So listen, I hope it helps out. If you liked it, hit the like button, subscribe, and have a wonderful day. And this is Here to You Moving Better. Okay.
Questions, if they have any.
Do you have any questions?
Someone
I got
was
a
asking
question.
if they could ask any questions.
Sure. There was one earlier that came over in the clinic about what's an epidural injection. You know, what's an epidural for? Let's talk about that real quick. I didn't realize we had some questions going in. My son is manning the comments here. One of the things an epidural injection will do is that a lot of times around these areas, where's my spine here? When we have, sometimes we'll have a disc herniation, and this is depicting the lower lumbar spine here. This is depicting, this little red area is a little herniation. And this is a portion of the disc materials coming out and edging onto the nerve roots that exit here. But what happens too is the belief is that there's some inflammation around that area, and that inflammation can contribute to affecting the way the nerve conducts. And it'll give you pain, tingling, numbness down the leg, different symptoms possibly. It can also give you weakness too. And that inflammation will affect those nerve roots that have little blood vessels in there and affect the quality of how that nerve conducts an impulse down your leg. This nerve will go all the way down to your leg and help with, you know, providing kind of the energy to the muscles or sensation to the skin, and give signals back and forth from the spinal cord down to the legs. So when inflammation is around there, the epidural, let's say cortisone based, that cortisone, that steroid, will drop the inflammation down, and people will have a rapid chance. Say, wow, you know, that pain's a lot better. And the hypothesis, the idea is that that inflammation was really the source of the pain. The disc was giving you some trouble. The disc was originally the problem, but that's not really what's giving you the pressure on the nerve. It's really that inflammation around that nerve root. So in certain cases, an epidural injection will really work well. You gotta be careful. I mean, when you do have a cortisone or a steroid-based medication, you can weaken the tissue around that particular structure. So you don't want to go about it too quickly. But in cases you do have to do it, and sometimes it's the right choice, you know. And when I say we want to try and find the best movements, there's times when you have to take medications, you need surgery, but you want to try and exhaust, beg, borrow, and steal before you go down certain routes, especially surgery, until you're absolutely sure. One of my mentors, Todd Olson, said you can't unring the bell. You know, anatomically things change a little bit, so you want to make sure it's really, you've exhausted all options before you go ahead and do that. Ryan, is there any other questions that have come up?
None so far. I just let anybody know if they had any questions to type it up.
Yeah, please post some comments and questions and anything on there. I'll try and answer. I try and answer as many as I can get to, and really just, you know, keep exploring other options. There's the back treatments. The variety is quite extensive as far as how people approach this. This is our approach, and we know pretty quickly within 2 or 3 visits whether this is going to help you. You can try those exercises, but just try one of the 3. Don't try all 3. Try one of 3 and realize it should not make you feel worse. And unfortunately, it doesn't replace a good evaluation and really a good guidance there. And when in doubt, I would see a professional, if not me. You know, see someone so you can get some guidance and make sure you don't make things any worse. All right? Listen, thanks so much for listening, and I hope this helped you out and at least educate a little bit more on what to expect with the back problems. Good night.
All right.